All right, good afternoon, everyone. Thanks for choosing this for your breakout session today. So I'm going to be presenting the first study of my PhD work today, which involved qualitative interviews with family members of people who use methamphetamine. Firstly, I'd like to begin by acknowledging the traditional custodians of the lands we're all gathered on today, the Gadigal people of the Eora Nation, as well as the people whose lands most of this work was conducted on, the Darug and Guringai peoples. I recognise their continuing connection to lands, waters and communities, and recognise that sovereignty was never ceded. I pay my respects to elders past and present, and extend that respect to any First Nations people listening today. I'd also like to acknowledge a few groups of people that made this study possible. So firstly and most importantly, I'd like to thank all the participants for sharing and trusting us with their stories. I'd also like to thank the research team and the advisory group that was formed specifically for this study, which involved service providers and people with lived and living experience. So having a family member who uses substances can influence family dynamics and functioning. The person using drugs can become the focus of the family, and difficulties with communication are common. Family relationships may reduce in quality, leading to distress for the whole family. All family members generally also experience high levels of stigma, which they receive from extended family members, friends, the wider community, and service providers. Given the association between methamphetamine use and certain interpersonal behaviours, such as agitation and paranoia, it's likely that use of this drug has specific influences on family relationships. Past research on families in an AOD context has generally focused on the parent-child relationship, so either looking at the influence of parental drug use on children or exploring parents in experiences of being a parent to someone who uses drugs. Less is known about experiences of other relationship groups, and to our knowledge, only two previous studies have explored the experiences of various family members of people who use methamphetamine. So the aim of this study was to add to the literature by focusing on the influences of methamphetamine use on various family relationships. So we conducted semi-structured open-ended interviews with 19 family members across Australia, and we used the family drug support definition of family, which is family, friends, and anyone who cares. All participants were adults who self-identified as a family member of someone who uses methamphetamine, and participants were primarily recruited through family drug support, as well as Facebook advertising and word of mouth. All interviews were conducted through Zoom or over the phone between June and August last year, and interviews lasted about 55 minutes, and participants were reimbursed $50 for their time. All of the interviews were transcribed and analysed using Braun and Clark's thematic analysis. Most of the family members recruited were female, straight, and living in Victoria. None of them had recently used methamphetamine themselves. Despite employing purposive sampling to recruit a range of family roles, about half of the sample were mothers. This is pretty typical of family studies, and we were able to recruit people who identified as siblings, partners, and a father and close family friend. It's important also to note that half of the sample had received support from family drug support prior to participating. Just another couple of caveats to keep in mind when interpreting the quality of results. Family members were naturally unaware of the exact patterns of use of their person, and individuals who were interested in participating were more likely to have experienced some negative impacts in their relationship. And as I just mentioned, half were seeking support for these impacts. So although this particular group primarily discussed negative influences on their relationship with the person using methamphetamine, it does not represent the experiences of all families or all patterns of methamphetamine use. And so over the next few slides, I will just be sharing some quotes that you can read in your own time as well. And just to note that all of the names included are pseudonyms. So the first theme described how when family members first became aware of the methamphetamine use, They mostly described the physical and behavioural changes they saw in their person, and this might be mood swings or sudden weight loss. Family members were often only able to attribute these changes to methamphetamine use after confronting their person. At this stage, they often felt that they were no longer dealing with the real person. They felt as though their person has become someone else that they couldn't relate to or connect with anymore. This was reflected in the frustration that participants often felt when interacting with them, as they often felt that they were unsure how their person would react. Zara's emotional quote here highlights the despair she was experiencing in her perception of losing her daughter to methamphetamine use. Family members experienced grief in a number of areas. They mourned the person their loved one used to be and the connection they previously shared, and perceiving this connection to now be lost. Families felt helpless in watching their person go through difficult times and feeling unable to help. Witnessing acts of self-harm was devastating for family members, and many of them expressed concern over their person passing away. The families also mourned the potential future that they previously wished for their person, a future that they perceived to be no longer possible. The perceived loss of this future was not only due to the psychoactive effects of methamphetamine use, but also on the social limitations that methamphetamine-related stigma would place on them throughout their lives. Families usually went through an initial stage of hyperfocus on the drug use and believed that they could fix it if they just found the right treatment. This period was associated with a range of emotions, including shock, disappointment, and despair. Interactions with their person centered on imploring them to seek treatment. And family members also often frequently checked in on their person, which was interpreted as nagging. Conversely, family members often received constant demands for money and sometimes verbal abuse if they declined. Overall, these types of interactions led to increased strain and tension in these relationships, and families grieved the absence of the loving, supporting conversations they used to have with their person. Family members felt that these influence of methamphetamine use on the family life was sometimes all-consuming. Family life was described as chaotic, and a sense of uncertainty and concern prevailed. Unexpected absences of the person using methamphetamine from the home were common, as were confrontations between them and other family members. This led some family to feel uncomfortable and sometimes unsafe in the home. Some participants saw their workplace as a welcome distraction from this chaos. Other participants, however, experienced a reduction in their ability and motivation to work. Some were unable to focus, had poorer decision-making skills, or had no desire to go to work. This meant many participants had to take time off from work. Apart from getting relief from going to work for some family members, others received a reprieve when their person entered residential rehabilitation. The initial rehab episode was met with relief, joy, and pride. Families were optimistic about what this meant for the future of their person and the rest of the family. When their person eventually began using methamphetamine, however, these feelings of elation quickly morphed into disappointment and distress. The cycle often repeated many times, and families eventually lost hope for this potential future. Levi here described his experiences of his brother entering and exiting rehab as an emotional roller coaster. After experiencing these influences of family life for a period of time, participants began to establish boundaries around their interactions with their person. These boundaries were an attempt to minimize these negative consequences while still maintaining a relationship with their person. Limiting the provision of financial support and restricting their access to the family home were common. Despite knowing these boundaries were necessary and beneficial for all parties, they still took an emotional toll on family members and were not easy to establish. Relationships between the person using methamphetamine and their siblings were particularly complicated. Siblings expressed concern, compassion, and frustration in these relationships and tended to resent their sibling for using methamphetamine and monopolizing their parents' attention. Siblings also witnessed their parents going through distress and acknowledged that this placed parents in a difficult position, as they often felt like they needed to intervene and mediate the relationship between their children. All participants described being judged, criticised, and blamed for their person's substance use. Many had lost friendships after disclosing their person's drug use, and this led them to be reluctant to reach out to others in the future. When they did reach out, they often received unhelpful and sometimes harmful advice, usually along the lines of their person should just stop using or that the family should just cut them off. These experiences of stigma were especially felt by mothers, who were frequently blamed for their child's drug use. Overall, many participants described feeling socially isolated in their experiences of stigma. By the time of the interview, most participants had a more positive outlook on family life. They'd begin to develop a greater sense of resilience and had a more appreciation of putting themselves first. And although the stigma had made some families reluctant to seek out for support initially, those that did contact family drug support were able to appreciate that others were going through similar experiences as them, and these groups helped them to improve the way they communicated with their person and led to healthier relationships throughout the whole family. So a central finding of this study was that stigma underscored all participant experiences. This was right from the moment that families discovered their person was using methamphetamine, right into when they were trying to seek support for either themselves or their person from family or from support services. So this barrier to seeking support for families is particularly important because social support is constantly identified as very important for these families in benefiting their own well-being. So just a general finding from the study is the need to increase the awareness of these family support services so that families can get into these services earlier in their journey before they start really experiencing some of the negative consequences that were explored in this study. Thank you.
Thanks, Paige. Do we have any questions? We've got a couple of minutes. I'm interested in the issue of stigma. What were the sort of things, because that's come up very strongly in your conclusion.
Yeah.
What were the sort of things they were talking about in terms of stigma?
Yeah, so there were, particularly if they had reached out to friends or family that perhaps weren't aware of the situation initially, a lot of families would tell them what was happening and friends would either just shut down the conversation completely and not want to talk about it or avoid them in the future because they didn't want to discuss it. Or I think, as I mentioned, the advice that they would get particularly, people would just say, oh, why are you bothering with them? They're doing all these awful things, so just drop them type thing, which obviously if you are that person being told that is quite a hard thing to hear. But it was definitely pervasive in most relationships they had with others.
All right, you've got 56 seconds, so any final words you want to say?
I guess, as I said, increasing the awareness of family support services. I think even I wasn't aware of what services there were out there when I started my PhD, and I think people working in the AOD field, as we all are, should definitely get that, in their knowledge base. Yeah.
Did you ask the family members if they were making use of the family support services and if they found them helpful?
Yeah, so as most of the participants were recruited from there, it naturally came up with them and they definitely found it really helpful. I think maybe them being recruited from there, they might have been a bit biased. They were obviously fans, But yeah, they definitely found it helpful speaking with people going through similar experiences and that sort of thing as well. Yeah. Thank you.
Thank you so much, Paige. I've been asked to use the microphone. So next we have Dr. Alys Havard, who's an associate professor at both NDARC and the School of Population Health at UNSW, Deputy Director of NDARC, and her research uses linked administrative data to improve understanding of how medicines are used at a population level, including safety and effectiveness in real-world settings. Two main streams of research, one focusing on smoking cessation pharmacotherapies and the other on medicine use and safety during pregnancy. What a brilliant combination and just so very important. So she's going to be speaking to us today about the effectiveness of prescription smoking cessation pharmacotherapies during pregnancy, a multinational study. Take it away.
Thanks, Hester. So we're going from rich, smaller data to big, wide data. And just before I start, to note that I'm presenting this work on behalf of Alys Havard, who's on leave at the moment, but she led this particular piece. So I'm going to start with some background on smoking during pregnancy and why smoking pharmacotherapies might be considered at this time. First is that smoking is a leading cause of adverse pregnancy outcomes. It's a well-established cause of low birth weight, preterm birth, stillbirth, sudden unexpected infant death, and a range of other harms. And the risk of these harms can be reduced if women are able to quit during pregnancy, but under current practice that is only happening in 1 in 4 women who are smoking during pregnancy. Second, smoking in pregnancy is still relatively common. Oh, sorry, I've just missed the order completely. Anyway, with all of that burden in mind, it's important that we consider additional strategies for helping women to quit. And smoking cessation pharmacotherapies are an appealing candidate because outside of pregnancy, they're the most effective strategy available for promoting quitting. And when I talk about pharmacotherapies, I'm talking about the 3 pharmaceutical products that are licensed as smoking cessation aids in Australia and most other developed countries. So those include nicotine replacement therapy, or NRT, varenicline and bupropion. And while they are established to be effective in the general population, we don't know that they'll have the same effects during pregnancy. And that's partly because of the changed metabolism and absorption of medicines during pregnancy. There have been some randomised trials of nicotine replacement therapy and bupropion among pregnant women, but they've generally been too small to produce conclusive evidence around their effectiveness, and there have been no trials of varenicline among pregnant women. And a big part of that is that there's still a lot not known about the safety of these medicines when used during pregnancy. And because of that, clinical guidelines recommend against the use of varenicline and bupropion during pregnancy, and that nicotine replacement therapy can be used if the expected benefits outweigh the risks. So in these circumstances, we really need to rely on observational studies to get a large enough number of women exposed to these medicines to test their effects. So with that in mind, we set out to conduct a large cohort study of the effectiveness of these products during pregnancy in terms of quitting smoking. We compared pharmacotherapy against no pharmacotherapy, and then we also compared the different pharmacotherapies to each other in terms of their effectiveness. We conducted a cohort study using data from 4 countries. So that included data from Australia, where our data was restricted to that from New South Wales only. Then we also had data from New Zealand, Norway and Sweden. And in each of the participating countries, we have collaborators who hold routinely collected data for all women who've given birth in those countries over the last 20 years or so. And these data sets are constructed by linking together the information that's routinely collected in health system contacts. We've got records from a majority of different parts of the health system, but the most relevant to this study are records of births or pregnancies resulting in birth, where we have details of the pregnancies, and the linked prescription medicine dispensing records. So our study cohort included women who were recorded in the birth record as smoking in early pregnancy. and the measurement of smoking in early pregnancy varied across the participating countries, as you can see here on the diagram. Our outcome was quitting or not, which we determined from smoking status at late pregnancy or postpartum, which also varied in its measurement across the participating countries. And our pharmacotherapy groups included women who were dispensed one of the 3 pharmacotherapies after early pregnancy smoking status was measured and before late pregnancy or postpartum smoking status was measured. Now, just a note on our use of prescription medicine dispensing data to determine pharmacotherapy use in this study. You may be aware that nicotine replacement therapy is available over the counter as well as on prescription. And we only have data on the prescription dispensing. So this is obviously a limitation of our study, but as you'll see later when we get to the results, the majority of the nicotine use in our study came from the New Zealand cohort. And in New Zealand, the nicotine replacement therapy is really well subsidised, so it's so much cheaper to get it on subsidy that we don't see much over-the-counter use. So we think probably our results aren't dramatically affected by that limitation. So the analysis was essentially a straightforward comparison of the number or the proportion of women who quit in our comparison groups. But in doing this analysis, we were really careful to account for confounding, which is often present in studies where women or participants aren't randomly assigned to treatment groups. To do this, we came up with a list of all the factors other than pharmacotherapy use that we thought might influence a woman's interest or ability to quit during pregnancy. We obtained information on these factors from the multiple data sources available to us, and they included a range of sociodemographic and maternal health conditions. And really importantly in this study, also information on the number of cigarettes smoked per day, which we thought was critical to this work because it's probably an indicator of the level of nicotine dependence, which might influence quit rates. And then we used a technique called propensity score matching to make sure that these factors were balanced evenly across the groups we were comparing. So here I present the number of women identified as using each of the pharmacotherapies. You'll see that we had almost 8,000 pregnancies with nicotine replacement therapy use. And as I noted earlier, the majority of that comes from New Zealand. We had 500 or so women using varenicline during pregnancy and 70 or so bupropion. Unfortunately, that 70 or so wasn't enough for us to be looking at effectiveness, so that bupropion is not included in the results that I present from here. And then just the quit rates in the women that didn't receive any pharmacotherapy. That's pretty close to the 1 in 4 quit rate that I talked about in the background, but a little bit higher there in the Nordic countries. So here are our results, and what we have here is a forest plot, which just shows the risk estimates relative to that line up the middle, which is no effect. We've got relative risks here for nicotine replacement therapy overall, and then broken down by formulation. So we've got patches and then intermittent forms, which include gums and lozenges, and then the bottom row there is combination use. So that's use of both patches and intermittent forms simultaneously. You see that the majority of the risk estimates fall on the line, the null effect line, or close to it, which means basically the quit rates were no higher in women using nicotine replacement therapy compared to no therapy. But there is that one result there for nicotine patches in New South Wales, which deviates from the line and oddly shows a lower quit rate among women using nicotine replacement therapy compared to no pharmacotherapy. And then pretty similar pattern of results for varenicline. In New South Wales, no difference in the quit rates between women using varenicline and no pharmacotherapy. And in the Nordic countries, those results show a lower quit rate among women using varenicline. So as I mentioned, these are a bit strange, not what we were expecting. In particular, it's odd that some of the analyses showed reduced rates of quitting among women using NRT or varenicline. And I think it's not really plausible to say that this reduced rate of quitting was caused by pharmacotherapy. Rather, it seems that we've got some bias going on and that these results aren't representing their true effectiveness. Looks like we've got residual confounding with the women using a pharmacotherapy potentially less likely to quit than women who did use a pharmacotherapy. And we did try to account for these potential differences with all the factors that we included in the propensity scores, including heaviness of smoking, but it seems that we've got some residual confounding, which is obviously a bit of a shame. It leaves that question around the effectiveness of these medicines during pregnancy unanswered. But we do still have the results of the comparative effectiveness analysis. And the great thing about that analysis is that it's comparing like with like. So we probably wouldn't expect to see differences in the level of nicotine dependence between women on varenicline as compared to nicotine replacement therapy. So the results there, well, they're slightly more encouraging, but unfortunately still not that clear-cut. We can see that the risk estimate is above 1, but the confidence interval around that estimate is quite wide. So it can either be interpreted as greater effectiveness of varenicline compared to nicotine, or an equally reasonable conclusion could be that there's no difference in their effectiveness. So where do we go from here? Well, I don't think we're ready to throw out observational studies as a way of addressing this question. It is still the case that clinical trials of these medicines are not really feasible because of safety concerns, or if they are done, they're generally too small to provide robust evidence. So while that's the case, I think observational studies are the only practical way to get at this evidence. But our experience does indicate that better measurement of nicotine dependence is needed so that we can produce unbiased estimates. At the same time, we can be working towards larger trials of these medicines by providing more evidence on their safety during pregnancy, given that this is the barrier to clinical trials proceeding at this point. And I think this is particularly important for varenicline, which hasn't been tested at all in clinical trials, and has shown potentially promising results in our work, but also as being the most effective of the pharmacotherapies in the general population. And so if you attended the symposium last year, you might have seen our work on the safety of these medicines in relation to birth defects and showing pretty encouraging results. And we have work underway looking at a range of other safety endpoints among women using these therapies during pregnancy at the moment. Thank you.
Great, thank you. Any questions? I'll get my step count up.
I'm down from Queensland and we have a Quit for You, Quit for Two program, so they get free replacement. Do you have that down here?
We've got versions of it, Quit for New Life.
Okay, so
Yeah.
ours covers 12 weeks, so the mother and their partners can also go on the program.
Yeah, great.
So yeah, I found, because I do a drug and alcohol clinic, I'm a midwife and an RN, and have found really good outcomes with that, with women stopping and use with cannabis as well.
Yeah,
Because they put
okay.
tobacco into spin, so...
And is it nicotine replacement therapy, just patches, just intermittent, or combination? What's
A bit
the...
of both, so just depending on what they like. So
Yeah.
if they've got a lot of nausea, then they won't do lozenges or spray, so then it's more patches.
Yeah, great to hear. I'd love
Yeah.
to chat to you more about it.
Yeah, definitely.
Hi, Alys.
Hi,
I was
Julie.
just going to comment on the quite interesting findings that you're not finding a particularly positive effect of the pharmacotherapies.
Yeah.
And I wonder to what extent it might be that pregnancy alone might be a real driver for women to just give them that extra target to really quit just for these 9 months while I'm pregnant.
Yeah.
And I wonder, have any studies been done where we look at relapse rates following the birth between pharmacotherapies? You know,
Between pharmacotherapies.
or versus placebo, like are more women likely to relapse who aren't on pharmacotherapies? That, you know, that might get over that.
It's a good question. I think there have been trials, particularly in the UK, but I don't know the results off the top of my head. But yeah, it's a good question.
I just wondered about, because I know clinically the importance of counselling, behavioural support. you weren't able to look at that in this study, but yeah.
That's the disadvantage. I mean, the advantages of having large
Yeah.
data, but a disadvantage in that it doesn't have a lot of the information we might need. So we don't know if we're comparing to women that are getting a high level of support. I'd hope that the majority of them are getting some support, you know, given that 5As is a big part of midwifery care, but yeah, no record of it, unfortunately.
Great. Well, thank you so much.
Thanks.
Okay. Okay, now on to Danielle. Danielle Tran is a medically trained epidemiologist and research fellow at NDARC. 15 years research experience using real-world data, population-based routine data collection, leading multinational studies, investigating prescription medicines for smoking cessation, mental health, substance use dependence in pregnant women. Oh my God. She's going to talk to us today about trends in the use of opioid agonist treatment for opioid dependence in pregnancy.
Thank you so much, and thanks all for coming to this session. And yes, as Hester already talked about, so that's my in this presentation. So I would like just to share you some results about the extent of the use of opioid agonist treatment for opioid dependence in pregnancy. And I would like to acknowledge the funder for the project and the data infrastructure behind that, and data custodian, the data linkage agency. Without them, we definitely would not be able to conduct this study. And just quickly about the background of the study. So opioid dependence or opioid use disorder are associated with a range of poor outcome for mother, overdose that we heard about this morning, for baby, preterm birth, small for gestational age, low birth weight, and when at birth, the baby had a lot of complications that need to stay long in the hospital as well. And so it is recommended that women with opioid dependence, they should start treatment before pregnancy, and if not, they should start when they're pregnant as well. And so there are two types of opioid agonist treatment, methadone and buprenorphine. So we know that methadone the program in Australia has been for many years, since 1970s, and it has been the traditional treatment for opioid dependence in pregnancy. And buprenorphine is coming to the market and being registered for opioid dependence in early 2000, and recently it has been supported for use during pregnancy around mid 2010. So what we have been knowing about the use of OAT in our general population. So I just put up the graph here of a colleague at NDARC. So we can see that over the past 10 years, so the use of OAT has been increasing for about 50%. And just look at the color. So we see that the use of methadone has been quite consistent, but we see the uptake increase in the uptake of buprenorphine. However, in pregnancy, when the use of this treatment in pregnant women has not been evaluated in Australia in the last almost 20 years, and we don't know how many people using it, their characteristics, and also the outcome as well. So that is why we set out to conduct this study. Very, very simple. We quantify how many women using these two medications when they are pregnant, and then we also to see whether to the extent that they change treatment during pregnancy. And this is the data linkage study that I think you have already heard about it, that Louisa mentioned this morning. So basically, we have this pie of the linkages, everyone who received OAT treatment in New South Wales since 2001 up until end of 2020. And then we link with a number of administrative data system in New South Wales. And for this one, we have the codec as the old treatment linked with the perinatal data. So the perinatal data that Alys already talked about, so that include the registration of birth that born in New South Wales with at least 20 weeks of gestation or birth weight of 400 grams or more, and also we are lucky to link with other data to find out the characteristics of a mother using oat. And just quickly talking about how we identify a woman using oat during pregnancy. So I present here the two scenarios of two persons who have a multiple prescription of oat. So and then we can see that sometimes the prescription lasts longer than the others, and then sometimes they have a bit of break between prescriptions. So we put those prescriptions together to form to define an episode of treatment. So when they have a very short gap between the two consecutive prescriptions, we put them into as a episode of treatment, and then we identify when the treatment starts, when the treatment ends for each episode, and putting together with the perinatal data. So we have information about gestational age, we have information about when the baby was born, so we could just use the equation up there to calculate when the pregnancy starts, when the pregnancy ends, and then put the data together. We can see when a mother have an episode of treatment overlapping with pregnancy, so we define that is the use of opioid during pregnancy. Yes, so overall the old data, we have about 50,000 persons, and then when we link together with the perinatal data, we come down with about 5,000 close to 5,200 pregnancies that resulted in birth. That mother had a history of treatment for opioid dependence in the last 4 years, and then out of that, about 4,474 that used oat during pregnancy. And quickly talking about the characteristics of those mothers, and about 60% aged between 25 and 35 years old, and about a quarter coming from the indigenous background, and 10% born overseas, and about a third living in the major city, but also in the area that of SH disadvantage. About a third have a prior record of conviction or charge. And moving up about their health characteristics, so about half of them have had a baby before, and smoking is very, very much prevalent in this population. Hepatitis and mental health behavior disorders are about a third of them, and the majority receive treatment in the community setting. And when we look at the extent of use among those who had a baby, who had a history of treated opioid dependence, so we see that about 90% of them receive oat during pregnancy, so which is quite encouraging that most of them had used opioid when they were pregnant, opioid treatment when they were pregnant, and then when we break down by type of medicine, so majority methadone, and about 20% of them use buprenorphine. And looking into further about how it changed over time, so just the line on the top is the any use of oat, and we see that it's quite high, although it fluctuates, but it doesn't look like it's a dramatic change over time. But this middle line is showing the trend in methadone use, so we can see that it's decline over time, about like a half. So back 2004, it's about 73%, and then more recently it's about 40%. And in the meantime, we see that the use of buprenorphine in pregnancy going up almost by 300%. And also, look, we're also interested in how women change oat during pregnancy. So overall, altogether, we've we observed about 245 pregnancies that during that women had the change of medication, and further breakdown by the direction of change of medication. So most of them changed from buprenorphine to methadone. And yes, there's a very little, about 1% only change from methadone to buprenorphine. And I just want to highlight here that clinical guidelines recommend that change from buprenorphine to methadone, so to reduce the risk of precipitation withdrawal, and not advised to change from methadone to buprenorphine. So what we've been showing here is quite reassuring that they follow the clinical guideline. And how it looks over time. So we see that over time, the changing from methadone to buprenorphine is quite low and quite consistent over time. But we see the drops, a decline in the change from buprenorphine to methadone. And we see that buprenorphine was recommended for use in pregnancy around mid-2010, so that makes so much sense that before 2010 we see a lot of changing. So it's quite assuring about the adherence to guideline. And just quickly summarize the finding and then a few discussion points. So we are very this is very encouraging to see the high coverage of OAT during pregnancy, and seeing the increasing trend in the use of buprenorphine. So it's also like highlight the need for clinician or services to in terms of providing consultation for women when they come to see the clinic about the choice of medicine. And we know that buprenorphine, the retention in buprenorphine is lower than methadone. So those with having buprenorphine in pregnancy, they may need more help, more support to maintain throughout the treatment to gain the benefit for mom and baby. And yes, so I mentioned before that lovely to see that the change in the medication during pregnancy is pretty much follow the clinical recommendation. So yes, happy to take any questions.
Thank you so much, Danielle. Any questions? I'm guessing that you can't see whether there's a shift to long-acting injectable buprenorphine from the New South Wales data. Would that be right? Because what we're seeing is more women either staying or commencing on buprenorphine during pregnancy, but do you have any idea what's happening with the long-acting?
This is great questions, and I hope that we can run in the more updated data, but at the moment the old data in New South Wales doesn't distinguish between type of buprenorphine. Yeah. And we try to account for the presence of buprenorphine in custody setting. So we take it like 1 month supply instead of just a week supply. Yep. So.
Any other questions? I had just a question about your idea what a treatment episode was and how you measured that. Because when I looked at that, it looked to me like it was authorities rather than prescriptions.
Yes, this is authorized prescription. That's what we have in the
but it's not actually the prescriptions. It's a particular prescriber being authorized to prescribe for a period of time.
Yeah, so we use on that. Yeah, so it's not really.
It's not really prescriptions.
Because
I was just thinking, how on earth did you get that data on the prescriptions? Because that would be really tricky to obtain.
In the old data we have the start date of prescription and then sort of the end date. So we use that.
For the authority. Yeah, that doesn't mean that person's on treatment throughout that whole time.
Agree.
Yeah. Okay. Well, look, thank you so much. That's brilliant. I could talk to you for ages about that, but we'll move on. Next, we have Bianca Varney, who's a Senior Research Officer at NDARC. She's a Scientia PhD scholar for the School of Population Medicine, an emerging pharmacoepidemiologist who specialises in the use of big data to understand the use and safety of medicines during critical perinatal periods. So she's going to be telling us about the use of opioid agonist therapy in pregnancy, timing of initiation and treatment retention. Beautiful follow-on from what Danielle's been talking about, and so very important. Thank you.
Exactly. Thank you. Today I'm going to be talking about the use of opioid agonist therapy in pregnancy, and this study was specifically looking at the timing of initiation and treatment retention in pregnancy. So I'd like to quickly acknowledge the Neuroscience, Mental Health and Addiction, the Unit C grant, as well as the OATS 2 program and the data custodians and linkage agencies. So Danielle's provided such a wonderful background. I'll hopefully go through this quite quickly. So untreated opioid use disorder, or OUD, increases the risks of adverse outcomes for the mum and infant. And opioid agonist therapy, or OAT, which includes methadone or buprenorphine, is the standard care for treatment of OUD in pregnant people. Engagement with OAT not only helps prevent things like withdrawal and relapse, but also increases engagement with prenatal care. And together, all of these factors really help mitigate these risks of untreated OUD. However, for these benefits to be gained from OAT, maintenance in opioid therapy throughout pregnancy is critical. And research has found that low retention rates in pregnancy can cause an increase in risk of adverse outcomes such as preterm birth. But people with OUD can have trouble maintaining treatment. They have a high risk of relapse, and these can be due to challenging circumstances such as unstable personal circumstances, issues in affording treatment or accessing treatment, as well as social barriers such as stigma. In pregnancy, we also think that the timing of initiation could be a factor that's related to to treatment retention. So women that start their treatment prior to conception probably have had more chance to build a rapport with their healthcare professional, become more stable on treatment, and just have an increased access to the healthcare system. So the evidence for OAT retention in pregnancy, or contemporary evidence for OAT retention in pregnancy, is kind of lacking. Outside of pregnancy, we see that buprenorphine retention is lower than methadone, but it has improved over the recent years. There is very little information about retention in pregnancy, though. There's a randomized control trial the mother trial, that found that the discontinuation rates were higher for those who were on buprenorphine compared to methadone, and some preliminary research from the US has also found similar trends in observational data. So given this, the objective of this study was to characterise the patterns of OAT use during pregnancy in the Australian context. And we wanted to do this by investigating first the timing of OAT initiation, secondly, the retention in treatment during pregnancy, and thirdly, the characteristics associated with retention in treatment. So similar to, the exact same thing that Danielle has talked about, we used linked data on all individuals within the New South Wales opioid treatment program. So this is a data set that's linked with information on New South Wales births, criminal convictions, hospitalisations and emergency department records, criminal convictions and notifiable disease conditions. So the source population, there's around 11,500 pregnancies in individuals in the OAT treatment program between 2004 and 2021. We were interested in individuals that had received an OAT treatment during pregnancy, which we defined as any treatment that overlapped with the start of pregnancy or when it actually occurred during pregnancy. And our final population was the 4,476 pregnancies. So to piggyback off what Danielle had mentioned about the episodes, I'm not really going to talk about them, but we used the OAT episodes that we had defined to examine the timing of initiation, which we defined as whether a treatment started before pregnancy or during the first, second, or third trimester. We also looked at the retention in pregnancy. To do this, we looked at the total time spent in treatment from the start of pregnancy until childbirth. So that involved just adding up the number of days in treatment through all of those OAT episodes, and then dividing it by the duration of pregnancy to kind of get the percent of pregnancy that was covered by treatment, covered by OAT treatment. So in my two examples, the first example I've got is that a woman started their OAT episode before pregnancy, but we're only looking at the days in treatment since conception, and we're dividing it by the duration of pregnancy. In the second example, a woman has 3 episodes during pregnancy, so we just summed up all those days spent in treatment and then divided it by the duration of pregnancy. And we also, after we defined this retention, we looked at people that had 100% retention in pregnancy, so those that retained from the conception until the date of delivery, and those that did not retain 100% in pregnancy. We also looked at whether individuals were on methadone in pregnancy, buprenorphine in pregnancy, and based on Danielle's work, we also looked at people that switched from buprenorphine to methadone. So we just calculated the proportion of the patterns of OAT use for each kind of characteristic that we're interested in. So for the timing of initiation, we simply divided the number of women in each category. For example, first trimester initiation divided by the number of women that had received OAT during pregnancy. When we looked at timing of initiation by retention, we just divided women that retained in treatment for the first trimester divided by the number of women that had initiated treatment in the first trimester. And then we looked at the characteristics that were associated with retention in pregnancy. So we looked at maternal sociodemographics, OAT treatment characteristics, birth characteristics, and maternal medical conditions. So this first graph just simply shows the timing of initiation for women on OAT during pregnancy. You can see from the big pink bar that around 75% of women initiated their OAT treatment prior to pregnancy. Around 10% initiated their treatment during trimester 1, and then less than 10% in trimester 2 and 3. We also quickly looked at how many women were on treatment at the time of childbirth, just as an indicator of whether women were receiving their treatment at the end of their pregnancy, and we found that 95% of women were on OAT at the time of childbirth. When we looked at retention in pregnancy, just reminding that we're only looking at 100% retention in pregnancy. When we found that methadone in red had the women on methadone had the highest retention at around 88%, and buprenorphine was a little bit lower. And then those that had switched from buprenorphine to methadone had quite low retention. When we looked at retention in pregnancy, according to when women initiated their treatment, we found that retention was highest in those that initiated prior to conception and was lowest in those that initiated in the first trimester. We saw kind of similar results that methadone in general had a higher retention than buprenorphine, although their confidence intervals overlapped within the trimesters, within the trimester categories. We then looked at characteristics associated with retention. We looked at these among women that had started treatment prior to conception because we thought that these characteristics might be different according to when people had initiated treatment. So women were more likely to retain in their treatment if they had received OAT during pregnancy and had a child after 2016, if they had pharmaceutical opioids listed as their primary opioid of dependence, if they were over the age of 20 and over the age of 25. Women that were less likely to retain in treatment lived remotely, had a late first antenatal visit after 20 weeks of pregnancy, were on buprenorphine, had a mental health diagnosis of anxiety or depression, and were receiving treatment in prison. So we found it reassuring that around 75% of pregnant people were on OAT before conception. This was even more reassuring since OAT retention was higher among people that had started before conception. We found that in general, or at least in the preconception and overall buprenorphine retention was lower than methadone. For those that had switched between buprenorphine and methadone, their treatment retention was quite low, but we couldn't really distinguish whether that was why they had changed treatment. I haven't really looked into that. And potentially additional support might be needed to help women retain in treatment if they have those characteristics that we identified, like if they lived remotely. So the strength of this piece is that it's contemporary, it's population-based, and it's evidence that's needed. Some of the limitations are that those episodes that we discussed are based on the authorities. They might not represent the actual treatment duration that's occurring. We couldn't distinguish between a new long-lasting formulation of buprenorphine that has been introduced in 2019, which may have led us to underestimate buprenorphine retention. And there's some other important patient and behavioural factors that likely affect retention that we couldn't really look at. That's it. Thanks.
Great. Thank you, Bianca. Any questions?
But Hester mentioning around the dates, episode dates being based on authorities and not necessarily prescriptions, and not really being certain that they're actually retained for that whole time. I'm just wondering if we have a sense of how many authorities, I guess, we might see in a pregnancy, to know whether there's more than one at least, or the duration of episodes as we've defined it. Does that make sense?
Yeah, that makes sense. And from my recollection, most of them are under a single authority.
Right.
And there are a subset that have multiple authorities.
Right.
But I don't remember the numbers. But yeah, it definitely felt like a lot of them were under a single authority.
Okay, thanks.
I just wanted to ask about the buprenorphine retention.
Yeah.
Because I know back when buprenorphine first became available, we were very anxious. Yeah. We did the start low, go slow, and retention was poor with buprenorphine because you need to get the dose up quickly. Mm. So what I'm wondering, because you had, from 2001 or 2004 to 2022? Was that? Yeah. So did you find that retention with buprenorphine improved as the years went by?
Yeah, I can only speak to the characteristics because that's the only thing that I have in my memory now. And we included the year of birth and looked at whether OAT treatment interacted with the year of birth to kind of check that. And it still came up as buprenorphine having a lower retention. Mm-hmm. I'd be interested to see what it's like now that the depot is... like when we have that data, what it's like then, because I feel like that's probably a really big help for retention efforts in buprenorphine, especially if you live remotely.
Yeah, I mean, it's certainly in terms of the length of treatment, but then I'm thinking to myself, because we know things change in pregnancy, your pharmacokinetics and dynamics change, and we need to put up doses. Are we finding that the buprenorphine just isn't managing the treatment because of those changes? Is that a limitation of the medicine? And I think we can't tell from your data, but it's super interesting. Any other questions?
I just want to add that in this project, we did not look at the retention over time, but what I know that Kriana, she did a study, look at the retention over time in the general population, yes, and then retention improved over time. Yeah.
Did you find the difference with retention with the prescriber more so they're used to prescribing methadone or that's their preferred, or the woman's retention, like with the Suboxone, Subutex? Because it is very much dose related. You have to titrate, up and down through the different trimester.
Yeah, and we don't have information on dosages as well, so I can only speak to the latter. I kind of missed the first half of the question though, I'm so sorry. About prescriber?
Yeah, just the prescriber, is that their preference with methadone, or is it their preference then to change?
Yeah.
Because I very rarely see methadone.
Yeah.
Like women on methadone.
Interesting.
Very rarely.
Yeah, and definitely as Danielle's study's shown, I feel like the number of women on methadone in the later part of the study is very small. But I don't think we didn't look too much into the prescriber, but maybe that's something to look into. Yeah.
Great. Well, I think we're just about on finish time. We've got another minute if anybody wants to ask another question. I know I could talk about this for hours. So interesting. No, that was just I'm just going to put my hand up. Okay, look, thank you so much, and thank you to all our speakers. It's a really important area, helping women to access the treatment that they need for a serious chronic illness that has, significant risk of harms, and particularly during pregnancy, significant risk of harms for the unborn child as well. Thank you for all your hard work and for the brilliant presentations. And I love the work looking at the experience of families and the way that kind of changed over time. It was kind of like, I kept thinking of the stages of grief of, how you start out being hopeful and then you get overwhelmed and hopeless, but then you find a way to kind of manage it. So it's so important, and I think it's work that we don't often look at in terms of the experience of families and how important families and the people that love people who use drugs, who have experience of drugs, is in terms of their trajectory and their lives of meaning. So thank you so much, everybody. Really, really appreciate it. And thank you to our wonderful audience, and have a great afternoon.